But I think you guys are going to be more also asked to, let me just say, it would be helpful for you guys, I think, also to know about the medical treatments, the pharmacologic treatments. And here's just a list of these are some of the older antidepressants. These are the tricyclics, and this is, I think, in general, where the stigma about pharmacologic treatment for depression came from. The idea that there are a lot of side effects associated with these drugs, with antidepressants. There used to be a lot of side effects associated with antidepressants before Prozac came along, which itself has, relative to some of the newer SSRIs, has more side effects than even some of the newer antidepressant treatments. But tricyclics are on the other hand, are very effective in treating depression, and should be considered because they are also helpful in addressing neuropathic pain. So if patients have comorbid depression and neuropathic pain, these can be helpful. Instead of having people on 2 drugs, it can be helpful to at least try a tricyclic antidepressant or some of the newer medications that also have been shown to potentially work in that regard.
Are the doses the same? Like sometimes you give a small dose for neuropathic pain.
Right.
Are those effective for depression generally?
Well, in general, the lower doses are effective for pain, but may not address the depression. That being said, though, I think with palliative care patients, with the frail elderly, you're always treating people with lower doses, and lower doses, in fact, may be effective. So I actually put in, the left column has some of the common doses for depression. The right column has doses that are thought to potentially be effective in palliative care patients. 25 to 125 milligrams of a lot of these medications can even help some of the mood symptoms. I mean, I don't use them.
You use 2 sometimes, like a low dose of the tricyclic for the neuropathic and then add another antidepressant, or you tend to maybe boost...
Usually I try to stick with 1 drug, but, you can add 2. Sometimes I will... and there's also, in terms of pain, I've often found, the non-antidepressant medications to sometimes be more effective, actually, than well, maybe not the tricyclics, but the SNRIs, like Lyrica or Neurontin. But, if someone has a depression, I will often try to use 1 agent. The secondary amines, nortriptyline and desipramine, they're called that because I think there's a demethyl. They're derivatives of the tertiary amines, but there's a demethylation which actually makes them in some ways more tolerable than they have fewer of the side effects than are present in some of the tertiary amines. So these are some of, like nortriptyline is one that is commonly used for pain, and depression is a little bit better tolerated, doesn't cause as much of the sedation or some of the orthostatic hypotension that the other ones can cause. The other symptoms that are concerning are anticholinergic symptoms with these drugs. Again, the secondary amines are less risky in that regard, but that risk is still present. Doxepin and Elavil are particularly sedating, which may or may not be a side effect that you may want to take advantage of in terms of helping someone sleep. When we treat sort of insomnia related to psychiatric disorders, we, typically figure out what the psychiatric disorder is and then treat it with something that's, the agent that's appropriate for that disorder. So, for instance, for depression, you might use a tricyclic or trazodone, which is a sedating antidepressant, whereas for a bipolar disorder or for schizophrenia or psychosis, you might use an antipsychotic, a sedating antipsychotic, or for someone with anxiety, you might use a long or short-acting benzodiazepine, if specifically their insomnia is related to worries at night. These are some of the SSRIs, and again, I think I put in the parentheses there, some of the ranges that you can push doses to. The lower end of the range, like Prozac is typically thought to be 20 to 60 milligrams, but again, you should start low. And Prozac, you might even half these doses in this population, so you might start at 5 milligrams, which would require liquid formulation. I usually start with Celexa, citalopram, or Lexapro. You can remember by the name that Celexa is the more selective of the SSRIs. It's sort of the cleanest of the SSRIs. It doesn't have, other than its serotonin reuptake inhibition, doesn't have much of at all in the way of other receptor activity. And then these are the two SNRIs. There are actually a couple others that have come on the market, although, there's one other called Menalciprem, which I actually have only used once, but not for depression, for pain, and that's the indication. It's for fibromyalgia. It hasn't been studied, I don't think, as much in depression. Wellbutrin or bupropion is unique from the SRIs or the SNRIs. It can be more activating. Can be something that's useful to try in patients who have, fatigue or hypersomnolence during the day along with their depression. The other thing is that some people, there has been some evidence that Wellbutrin may be a little bit safer for patients with bipolar disorder. So if you don't want to start someone on a mood stabilizer, but you have to sort of hedge, you can try Wellbutrin. It's a difficult issue, I think, in general. Bipolar disorder is something that has become, something we have to be careful about and screen for, but, perhaps as a field we've become excessively concerned with it. So it's something that we want to be wary about. We want to titrate the antidepressants slowly and make sure that that patients aren't becoming manic, which is a risk with people who have a tendency towards bipolar disorder if you prescribe them an SSRI. But that being said, I think that's the safe way to go instead of automatically planning to prescribe two agents, a mood stabilizer and an antidepressant, a lot of the time. Trazodone is not something that I've used. These are medications that have unique and complicated pharmacology. Trazodone is not something that I've typically used for primary depression treatment, but is a good medication for, as I mentioned, insomnia in patients with depression, and it works at much lower doses than the range for depression. The antidepressant dosing range is between 200 and even 600 milligrams, whereas 25 milligrams to start of trazodone may be helpful for insomnia. But people do kind of develop a tolerance in some ways to the sedating effects of trazodone. So over years, anyway, you might find, or over many months, you might find that you need to go up on the dose to get that sedating effect. Remeron's kind of the opposite, and it's been hard. In theory, it's a good drug in this population because it helps. Also, it's sedating, so it can help with sleep, but it also has appetite-stimulating properties. That being said, a lot of patients, even at low doses in this population, I've found have trouble tolerating it because it's so sedating. Even if you half the dose to like 7.5 milligrams, I've found that it's just been hard. People get very sleepy on it, and there has been some notion that it's actually less sedating at higher doses, but it might just be that it's not more sedating at higher doses. Like like if you push the dose, it doesn't increase the level of sedation.